Hello, everyone. I'm Julie Harwell, childbirth educator and labor and delivery nurse at Kittitas Valley Healthcare. Thank you for taking the time to view this wonderful presentation, Infant Lip and Tongue Tie Update, presented by Dr. Neal Smith, DMD. This is the first in a series of presentations we'll be sharing with the community. To learn about our childbirth and family education program at Kittitas Valley Healthcare, please visit our website at kvhealthcare.org for a complete list of classes. Before we get started, I'm going to review our disclosures pertaining to this presentation. There are no conflicts of interest for this activity. The information presented today is meant for educational purposes only. The views expressed are those of the presenter and do not constitute endorsement, recommendation, or favoring by Kittitas Valley Healthcare. For medical advice, please contact your healthcare provider. Now, to introduce our speaker today, Dr. Neal Smith was born and raised in Central Washington. He received a BA from Central Washington University in biology and a DMD from the Arizona School of Dentistry and Oral Health. He completed his pediatric residency at the University of Washington. After residency, he stayed on as faculty at the University of Washington and opened a private practice in Ellensburg in 2013. He is the only board-certified pediatric dentist in Kittitas County and practices with an FDA-approved all tissues laser. Dr. Neal, thank you for being here today. I'm now going to turn it over to you.
All right. Yeah, thank you, Julie. And thanks to Rozika as well for inviting me to discuss this important topic. And hopefully I can shed some light on maybe some confusion about lip and tongue ties and how to evaluate and treat if necessary. A lot of the information I'll be presenting with the community is from a recent American Academy of Pediatric Dentistry Summit meeting regarding lip and tongue ties. It's the first time the Academy's ever addressed this topic. And so there's a lot of research going into it, and I think it's coming to the forefront. And so I'm just happy to be part of the community and hopefully provide some information and share some information on this. And a lot of information I'll be presenting is from Bobby Gahiri, who's an ENT in Portland. I've learned a lot from him over the last few years, and as well as Larry Kotlow, who's a pediatric dentist in New York, and he uses the same technology to treat infants. So we'll jump right in. Thanks, Julie, for kind of covering a lot of this information. But yes, I did grow up in Central Washington. Opened my practice in Ellensburg in 2013. And this topic's really important to us. You'll see the little picture of our two daughters, and our youngest, my wife is holding the picture, had a lip and tongue tie release. My wife was really adamant about breastfeeding because the evidence definitely shows that it's very beneficial for the child. And so about 3.5 years ago, I invested in laser technology, and my wife was having lots of trouble breastfeeding. My new infant daughter was having trouble breastfeeding, and so we were able to diagnose her with a tongue and lip tie, and I treated it, and then she didn't want to stop breastfeeding. So she breastfed for about a little over 2 years. And so it kind of hits home with us. And my goal is to hopefully educate families and breastfeeding mothers and work with our wonderful IBCLCs, nurses, midwives, chiropractors, all the individuals involved in helping mothers that want to breastfeed. So we'll be covering a few topics today. The role, obviously, kind of talking about tongue ties, the role of tongue in breastfeeding, and identifying and classifying tongue and lip ties. So there's and the challenges those create. I think if we're all speaking the same language, it's very helpful when trying to talk about tongue and lip ties and whether or not there's a problem there. I'll cover 4 or 5 current research papers that identify and support possibly early treatment. And then we'll go over a little about treatment options and what we do and how I treat infants. So first, we have to learn about the tongue, right? So it's one of the most important structures in the human body. It's very complex. There's extrinsic and intrinsic muscles that control sort of the gross movements and fine movements. You kind of think of the human tongue as a elephant's trunk or an octopus arm, because it doesn't change in volume, but obviously it has many complex movements to it. And it's the only structure in the body that's a muscular hydrostat, which means it's not really attached to any bone. It's sort of suspended in an arc in the mandible. So it's a pretty amazing structure, and it allows lots of movements. And obviously it's attached to the floor of the mouth by something called the frenulum. And so that's kind of what we'll dive into, what a frenulum is, what it looks like, how does it work. Movements of the tongue, we retract it, we protrude it. So we don't want our kids to protrude it out in public, but at the dentist, that's okay. And then we depress the tongue, it can elevate, and elevate is the most crucial function in terms of breastfeeding. So if the tongue doesn't elevate, breastfeed is difficult. And so it facilitates feeding, sucking, mastication, swallowing, speech, and taste. So we'll dive into more about the function of the tongue here. There's fascia under the tongue, and it extends all the way through the body, all the way to your toes. So that's one continuous band of fascia that runs throughout your body. And so there's lots of research going into sleep apnea and posture and the effect a tongue tie might have with that. So it's very interesting. And there's multiple layers, right? There's mucosa, there's fascia, there's muscle. And so I like the picture on the right. It shows the tongue sort of suspended and attached to multiple muscles. And especially if you look right here, this is the genioglossus muscle, and that's directly under the tongue. So one sign of complete release when you have to release a tongue tie is that the genioglossus muscle is exposed and is popping out and able, because it's covered by fascia mucosa. If that's exposed, then the tongue will be able to elevate appropriately. So that's definitely one thing we really look at when doing frenotomy procedures. And this is a good example of just a look at the lingual frenulum. So it attaches, of course, under the tongue, the ventral surface or the bottom of the tongue, and that lingual frenulum comes all the way across and will attach somewhere on the mandible or floor of the mouth. So there's lots of variability. And Nikki Mills is a pediatric ENT surgeon in New Zealand, and I heard her present at the last AAPD meeting, and she did a lot of dissections and looked at anatomical research. So this is from Nikki Mills' paper, and kind of that red area is mucosa. So it's kind of like looking at the tongue. Red area is mucosa. The green area is connective tissue, and then the bright green is foramouth fascia. So some people think, oh, well, it's just a little string or it's a little band under the tongue. It's really not. It's a melded group of tissue that it's just layer by layer. So there's a lot of variability in how the frenulum attaches and how that tongue is shaped. So sometimes it can be really thick, sometimes it can be a tiny band. And that frenulum is made of collagen and elastin. It can be very elastic sometimes if there's a high concentration of elastin in the tongue. So it's really just kind of multiple tissues melded together, not a separate string, kind of layers gliding. There's been some talk of releasing all the way back and even going into the muscle, but that's, her studies and her anatomy shows that's really not necessary. That the frenulum actually doesn't extend very deep, but obviously if it's restricted, it can certainly lead to problems with breastfeeding infants or other challenges down the road, and we'll kind of dive into those. So how do infants breastfeed? So the current theory, a couple more recent studies from Getty's, he looked at ultrasounds of babies and how milk is transferred during breastfeeding. And it's really all about vacuum creation. So ELAD looked at tongue movement, and it always moves with the mandible, anterior mandible. So basically, we'll kind of go through a quick suck cycle. So the nipple is held in the infant's mouth by the tongue and oral cavity. You create a seal. The jaw will start to drop, and along with it comes the tongue. And vacuum will increase. Negative pressure started to be created. Ducts start to expand, and the milk starts to flow. And when the tongue reaches its lowest position, its peak vacuum and milk flow starts to flow into the oral cavity. As the tongue rises slightly, the vacuum will decrease, and then the positive pressure from the maternal milk ejection occurs, and you get milk flowing past the soft palate down into the pharynx. So this is one complete cycle of breastfeeding. And so I guess in the past, it'd been more peristaltic movement was the key, but it's really about creating the latch, creating negative pressure, and that's how infants feed. So you can see how a tongue restriction can definitely lead to challenges with creating a seal, creating that movement, possibly pulling air in if it doesn't seal very well. And so really the objective is to try to remove those vectors that interfere with that latch, interfere with that suck cycle. So what can impact vacuum creation? Of course, tongue, that's what we're talking about, is how does the tongue move? How does it create that vacuum? Lingual frenulum. So that lingual frenulum attaches the tongue somewhere and is that restricting movement. The mandible, there's certain syndromes like Pierre-Robin where the mandibles might be small or retruded, and that can interfere with feeding, definitely. The child might have a vaulted palate. Height and contour of the arch is important in terms of creating a seal. And there's, of course, maternal factors that can interfere with breastfeeding. So this is information from the CDC in terms of what are the new breastfeeding indicators. And this was from 2017, it's the most recent data I could find. So we're currently at the highest rate of breastfeeding in the past 50 years, which is great news. And the American Academy of Pediatrics recommends exclusive breastfeeding only for the first 6 months of life. And then food can be along with breastfeeding for at least a year is the recommendation. And the World Health Organization recommends 2 years or longer of breastfeeding. So here's where we're at. Highest rate of breastfeeding right now. So it starts off with good news. 84% of infants at least get some breastfeeding. But unfortunately, that percentage drops to only 58% at 6 months. And then at a year, where only a third of moms are still breastfeeding. So that's quite a drop off. So why does that happen? And then exclusive breastfeeding of infants is less than half for 3 months. And we're down to a quarter of moms at 6 months. And remember, that's the Academy's Pediatrics recommendation. And then a lot of infants, if they're having trouble breastfeeding early on, they do get some sort of supplementation with formula. So in the first 2 days of life, 1 in 5 infants ends up receiving some sort of formula because, I get it, the baby wants to feed, they're having struggles. So that's why we'll go over it in the presentation, but early intervention, early evaluation is really critical for moms that want to breastfeed. So we kind of look at why do moms stop breastfeeding. So I think kind of an unfortunate statistics from the CDC is that 60% of moms don't breastfeed for as long as they intend to. Why is that? Well, issues with lactation and latching, right? First off the bat, if they're having trouble, and breastfeeding's, very natural instinct for an infant, and many moms do want to breastfeed. So if there's issues with that early lactation and latching, that can be discouraging for the mom, and you can end up not breastfeeding, even though a lot of moms do want to. Concerned about nutrition, weight. So maybe it's a production, maybe they're losing weight, so they need to supplement, and then they get to exclusive bottle feeding. Medications. Luckily, work policies and parental leave, I think, have improved. But that certainly can be a barrier. And then, if generations of moms aren't breastfeeding, if in the family, there's not really family support, that certainly can be a deterrent to breastfeeding. And, I think the hospital plays a key role, obviously, in getting that early evaluation, because the infants are born there, of course. And if they can get that early support, then, and encouragement, then, breastfeeding can definitely continue and improve. So what happens if we don't breastfeed, right? So we know that's really the best nutrition for the infant, but there's a significant financial burden to not breastfeeding, including death or illnesses early on. Long-term sequelae, only half of women with breastfeeding problems will continue past 1 month. So if there's lots of struggles early, breastfeeding ends. Untreated tongue-tied children. So if we diagnose tongue-tied very early on, 300% more likely to have bottle feeding at 1 week of age. So, we have to transition to something quickly, and that's the bottle. Short delay in treatment increases bottle use, discomfort for mom. That's not going to improve if they're continuing to try to breastfeed. And again, one of the big things down the road is kids that are breastfed have three times more likely to if they're breastfed, they have less orthodontic problems and airway development issues. So that's something we're looking at, because the breastfed babies, the nipple kind of shapes the palate as they feed. So it doesn't happen any other way. Even with a bottle, it's more elastic or more rigid. So the palate can be expanded a little bit when you're breastfeeding, and so that can create better orthodontic health down the road. So how much does this really occur? How often do children or infants have oral restrictions? So that's an important thing to look at. And most of the past literature, although the technique for diagnosis or classification wasn't great, most of the old studies will say 10 to 12% of infants have some sort of anterior tongue tie. So that's not including posterior tongue ties, which can be another problem, and we'll talk about that. It's much more common in males. So that's something when you're evaluating an infant, we know that males have a higher likelihood of having tongue ties. And then, we know there's definitely a genetic component to tongue ties and lip ties. So autosomal dominant, Clockers in 2009 said autosomal dominant with variable expression, which means only one parent has to have the genes for tongue tie or lip tie, and one of the children can end up with tongue or lip tie as well. So because of the variable expression, not every child with a parent of a tongue tie will have a problem, but definitely that's something to look out for. And I've seen multiple siblings in families many times. So those are kind of like the numbers, but I have some research I'll present later that shows that this may be a bigger problem than we initially anticipated or thought in the past, and we'll look at that. And I think it's better congruency in evaluation and diagnosis. So what happens if we don't do anything with tethered oral tissues like tongue or lip ties? So from a dentist perspective, we look at dental caries. So if the lip is really tight and say the infant is feeding or the child is feeding with milk at nighttime or food, so plaque and milk will sit right there attached to the lip, to the teeth, and you can end up with higher risk for dental caries. So that's one thing we worry about. Diastema is just a space between teeth. So sometimes that can be an aesthetic challenge, but if the frenulum on the lip attaches all the way to the palate, then it keeps those teeth apart. And so that's what a diastema is, and a lip tie can definitely contribute to that challenge. And then trauma. So we know that kids with lip ties, and I see it every few months, is a kid will fall and tear their frenulum. Some providers will say, well, don't worry about that lip tie. You might fall and tear it and bleed, and it's no big deal. So I don't know whether the medical advice we say, hey, if you tear a body part, you'll be okay. So, but yeah, sometimes those can be need to be treated, but it's case by case and looking at the big picture. When we look at tongue, obviously we're talking about breastfeeding today, so we kind of getting the understanding that a tongue tie can definitely interfere or create challenges with breastfeeding. as well as speech, mainly RSs, THs. So I do work with a lot of speech therapists too that help us identify or see if a tongue restriction is creating a challenge with speech. And dental caries, believe it or not, your tongue will move laterally to clean the top surfaces of the lower molars, especially. And so that'll help keep the teeth clean and prevent dental cavities. And then again, kind of touching back, is sleep disordered breathing is becoming a hotter topic as well. And children with tongue ties do have a higher incidence of having some sleep apnea, sleep disordered breathing. So it's something to evaluate. And then right now I'm gonna kind of hold on the screen share. And I'm going to talk about, we're going to go through an evaluation technique, because I think it's very important to evaluate tongue and lip ties and do it in the same manner so we can get proper diagnosis. So I'll pull that up. So this is courtesy of Bobby Gahiri. He's in the ENT in Portland. He's got an amazing website. So, and this is the evaluation technique that I use in my office. And I think any provider that's looking at tongue or lip ties for infants, this is really the most accurate way to evaluate. So I'll kind of go through it and we'll kind of stop right there. So you can see middle and ring finger are under the chin, kind of stabilizing the lower jaw. And then his index fingers are lifting the lip. So first we're evaluating the lip. And this is what I do very systematically, is get both index fingers under the lip, and we'll kind of flare it out and see where, not only where does the frenulum attach, but how restrictive is it when you're trying to move it. So here's the frenulum kind of stretch. And you can see when he stretches it up, the lip is really creased and it's uncomfortable. It's not flaring out, it's not flanging over the nostrils, which was what we want to see for the extension on the lip. And then for the tongue, you kind of swipe the index fingers on both sides, and you're going to want to try to get under that tongue. If you once you swipe and stretch, that baby's tongue will come out, and then you can get underneath it and lift, and you can see that frenulum very well in that picture. This would be a little more posterior of a tongue tie, so it's hard to identify without a good evaluation. So it's kind of like a forklift technique, getting under and lifting the tongue. And he does it one more time here. So kind of stabilizing the lower jaw, getting the index fingers in, baby's head is in your lap. That's really the best way to evaluate tongue and lip tie. If the baby's tongue's not in your, or baby's head's not in your lap, you can't really see. So this is a classification system from Larry Kotlow, who's a pediatric dentist that I, like I said, learned a lot from. He uses the same technology as I do to treat infants. And so we'll go through one by one, like knowing how to classify lip and tongue. So you can see here the frenulum in the class 1 is really, it's not tight at all, right? It's not attaching very low. The lip flanges out. That's a non-issue. That's normal anatomy, and the frenulum is normal. Everybody has them. It's just where it attaches and how it restricts movement. A class 2 frenulum is it attaches primarily to gingival tissue, so it's not really getting down lower where the teeth are or wrapping around to the palate. It's just attaching right at the mucogingival junction. So the mucosa is the red above and the gingiva is kind of the white tissue below. So if it kind of attached right there, really shouldn't create much of a challenge for class 2s. Then class 3s, you can see, we kind of go to the lower left side there. It inserts just in front of the anterior papilla. So it's a pretty is starting to get more restrictive, right? It's a longer band of tissue. It inserts lower, and that might prevent that lip from folding up. And you see in this picture, there's the infant's nostrils right here, and that lip has a lot of tension. You can see it blanch around the frenulum, and it doesn't really elevate. The lip doesn't elevate out. So that can start to be a little more restrictive, and may indicate further evaluation. And certainly the class 4 lip ties, where the frenulum is attaching to the palate, those ones may indicate treatment. So you can see where the lip is sort of appears like it's pulled down, and the baby has a callus on the lip because that frenulum is not folding out at all, and it's not covering the nostrils at all. It's so you can see this lip definitely has restriction in movement. Here's another classification system. I use the Kotlow system for the lip, but it's the Stanford Superior Labial Frenum. So the insertion is near the mucogingival junction in a type 1. So again, mucosa is kind of the red area, the gingiva is the white, and it's attaching kind of right there. Type 2 is where the insertion point is kind of mid gingiva area, and then type 3 is where attached down. You might see some notching in the bone, as you see in this picture. There's quite a bit of notching, and that's a sign that the fibers of the frenulum are attached to bone, and they can be more restrictive that way. And you almost see the lip creased right here. So that's definitely a sign that there is a lip restriction. And you kind of follow the pictures. One, see the lips flanged out all the way, covering the nostril. That's good movement. Two, we're not, a little less movement, and it's a thicker band of tissue. But the 3, it's not even elevating at all, and there's a lot of creasing of the lip. So those, in this scenario, the lip, frenulum may be a little more restrictive and may indicate some sort of intervention. And so we'll jump to ties of the tongue. And again, Larry Kotlow, one of the first people to identify and diagnose, classify lip and tongue ties. And he has a tongue evaluation. I don't use his for mine, but we'll go through it. Type 1, and here's the lower mandible, so the lower jaw, and the frenulum is attaching right to the ridge there. So these tongues generally have a heart shape to them. They're very restrictive because the tip of the tongue is attached to the lower jaw, so that infant cannot move that tongue very well. So you can imagine if this infant in this picture is trying to breastfeed, the infant can't even move their tongue up. So it's definitely going to lead to challenges. And then if you go to type 2, where you can almost see some cupping in the tongue. It's a few millimeters further back, the attachment, but type 1 and type 2 are generally considered anterior tongue ties. And then we get to type 3, which is distal to the midline. The tongue may appear normal, or it might have a small hump on the top. But the attachment of the frenulum is more towards the floor of the mouth and getting closer to the middle port of the tongue. Type 4 is a very posterior area, which may not be immediately obvious, and that's why using the technique I showed you with getting the index fingers under the tongue and kind of lifting up and back like a forklift, these frenulums will kind of pop out in that case. And so this is submucosa, meaning there's mucosa covering the frenulum. And so I would say these are less likely to cause problems, and sometimes they can cause major problems. And I have a case today I'll present that did cause a pretty significant problem with a posterior tongue tie that was treated. So I think, again, evaluation is critical. And this is the system I use. It's called Coriolis. So the frenulum, type 1, again, frenulum is on the mandible, attaches to the very tip of the tongue. There's no reason not to treat these, in my opinion, because if they don't lead to feeding problems, the baby has to accommodate somehow because that tongue's not moving at all. And then when you get to type 2, I like more 2 to 4 millimeters behind. So the Coriolis kind of classifies it more. It's 2 to 4 millimeters behind. So we're all speaking the same language. It's a class 2 or type 2. And then type 3, again, middle of the tongue to the floor of the mouth restriction. And then type 4, again, submucosa. Once you elevate that tongue a little bit, you'll see the band of frenulum pop through. And then here's a good schematic. If you look at the tip of the tongue to the lower mandible, that's a type 1. And then type 2, again, 2 to 4 millimeters back. Type 3 is even further back, more middle tongue. And then type 4 is under the mucosa. So I also go through and diagnose lip and tongue tie classifications. And then I use the tabby tongue assessment tool. So this is a quick, easy tool to use at anyone's practice. And you look at what does the tip of the tongue look like? So if it looks like a heart like this, it gets a 0 score on the tabby tongue assessment tool. So we only like hearts for Valentine's Day, not for tongues, because that means that tongue's not moving. So class 1 is you have a little kind of a dip in the tongue where it's not elevated. The tip is not, kind of a round, smooth appearance. And then if you go, where is it fixed? Is it fixed to the mandible? Is it fixed just a little bit behind the mandible, or is it fixed to the floor of the mouth? Where does that frenulum insert? And then you look at how high can the child lift the tongue up. So this is the most critical piece to breastfeeding. But if the tongue doesn't elevate at all, then we're going to have problems. If the tongue does elevate, but you have some roundedness on the top of the tongue, kind of it dips down quite a bit, then again, it's not elevating very well for breastfeeding purposes. And really, what we're looking for is this last one, which would be a 2 score on the tabby tongue assessment tool, where it does elevate all the way. So that's what we're really hoping to gain by the surgery. And then how far can the child stick the tongue out? They can't even move it past the back. They can't move it past the mandible. Then there's obviously restriction. I think this is probably the least important factor in the tool, but you can kind of assess how far they're able to stick the tongue out. And so a 0 to 3 score it signifies a pretty severe restriction for the child. So that may, kind of another assessment tool to add in, and looking at the big picture and whether or not treatment's indicated. So just because a infant is feeding and gaining weight, it doesn't mean they're feeding well. So many babies have to compensate for tethered oral tissue, and because their tongue and everything's not operating as it should. So they end up incorporating other muscles, the other masticatory muscles, the orbicularis oris that goes around the lips. And it creates inefficient breastfeeding or other problems down the road. So in terms of a lip tie, you get a small mouth opening, the lip doesn't flange out, as we saw in some of the diagnosis pictures. And it can force sort of a shallow latch. In terms of tongue tie, you can get impeded movement up, which you don't get the vacuum or the negative pressure creation, so you don't get any suction. And if you don't get any suction, you can't sustain a latch. And if you don't have a latch, you get compensation somehow from the infant. So some babies with tongue ties, obviously they are able to feed okay, but it's they're gaining weight, but they're not feeding very efficiently. So that's where we may look at intervening. And you can see in this picture, this baby has callous lips, pallor on the lips, but it's all white. They're not using their tongue for feeding. And so Bobby Gahiri, here, let me do one quick thing. Stop share. So, okay, see that okay, Julie? Yeah. So Bobby Gahiri in 2017 looked at a prospective cohort of 237 babies. So these were babies that were evaluated by IBCLCs and referred to him for possible tongue-tie treatment. So what are the symptoms of poor or compensated breastfeeding? One is poor latching. 81% of the moms, 4 out of 5, said latch isn't going well. They might fall asleep when attempting to nurse. Nearly 3/4 of moms with tongue-tied babies reported that. And then, misshapen, creased flat nipples, nearly, around 2/3 of moms. Same thing here. Sliding off, severe pain. So nearly 60% of moms with tongue-tied babies referred to him had severe pain when latching. So I think those moms are going to continue to breastfeed if it's extremely painful every time. Reflux symptoms is definitely associated with tongue tie, and that may be air coming in. How are they holding the pacifier? Many of these babies have struggle with that. A third of them might have some weight gain issues. They might be more colicky, and that was my own experience with our youngest daughter. She was pretty unhappy with reflux and colicky, and after treatment, those symptoms were relieved. And then a lot of more maternal, symptoms. But these are all associated with that compensation for breastfeeding, like we discussed. So this is probably one of the best studies in terms of support for early release or early evaluation. This is a randomized controlled trial of tongue-tie infants. Hogan did this in 2005. These infants all had feeding problems, were diagnosed with tongue ties. They took 57 babies, and they split them in half. So half of the babies received 48-hour feeding support only. So a nurse, lactation, supporting that mom with feeding. And then the other half of the infants received, because the tongue tie was already diagnosed, a frenotomy procedure and the feeding support. And overwhelmingly, 96% of the frenotomy group improved feeding. So, when you release the tongue, they're able to feed. 3% of the feeding support only group improved. So that's a pretty significant difference, and shows sort of the support for early evaluation, early intervention. And what they ended up doing was the feeding group only, feeding support group only, was offered the frenotomy after that 2-day period, and they all accepted, and the overall improvement was around 95%. For breastfeeding, and that's typically what I see. I would say around 90-95% of infants have improved feeding after a restriction release. So we kind of touched earlier that maybe the incidence of tongue and lip tie is around 10 to 12%. But a study from just last year in 2020, they published this cross-sectional study. They looked at all the neonates born at the hospital, and it was a hospital in Spain in 2018. And so all the providers evaluating tongue and lip ties got on the same page. They used the Coriolis scale. They looked at the infants. They tried to diagnose if there was a tongue tie, no problems. And a tongue tie was identified in 46% of the infants. So again, everybody has a frenulum, but whether or not it's restriction or whether or not it's causing symptoms. And 450 of those diagnosed with a tongue tie or identified as having a potential tongue tie, 450 of them had symptoms. So that's 70% of that group. And then they kind of took it further and said, okay, there's some restrictions that we can diagnose. Here's symptoms. Nearly a third of those infants had clinically significant ankylosing. So to them, that was restriction plus, symptoms. So that's a pretty significant number. And I think why the discrepancy from old data is that Type 1 tongue tie is pretty easy to diagnose. You don't have to be a healthcare provider to see a string on the tongue that, that appears really tight. So that was 7% of the babies. So that's why I think we kind of get right around 10% have that type 1 tongue tie, which is the most restrictive. And again, type 1, type 2 are anteriors, but these type 2s generally can cause a significant amount of problems as well. And that was 35% of that group. And then you get to type 3 and type 4 are the submucosa ones. So it may be a bigger challenge. Obviously, it's just an isolated study, but it could be, I think it just goes back to early evaluation and support if needed. There's really not a lot of good data on treating lip ties. This is one of the studies that's pointed to mostly. It's Patel in 2019. They looked at 22 mother-infant dyads and were diagnosed with a lip tie. This was a retrospective review, so they looked back at the data and asked the moms well after the procedure. They used thermocautery, which basically just burns the lip attachment, so that doesn't sound very good to me. But 82% improved latch, 73% improved satisfaction with breastfeeding. This is just mother reported, and a 10%, 9% recurrence rate. So that's pretty typical. So like I said, not a lot of evidence for lip ties, but definitely this is one study that said, hey, if it's really restrictive, we may get some improved feeding. And this is one thing we definitely know is that early intervention matters. So a 2005 study said, untreated tongue-tied children, 300% more likely to bottle feed at 1 week of age. So they're, and sometimes it's hard to go back to breastfeeding if you're exclusively bottle feeding. And Todd in 2015, I think this is very interesting, is he looked at a group of babies in 2008 where the average age of intervention of tongue-tie release was 6.5 days. Bottle use in that group was already at 3%, and nipple pain for mom was 85%. So at a week old, about, we're already starting to transition to the bottle, mom's having pain, diagnosed tongue tie. In 2011, they had the group of babies, and then average age of intervention for tongue tie release was now almost 10 days. So we're at a week and a half. Bottle use had increased 6-fold, and nipple pain is not, typically not going to get better. So there's that 97%. So I think what it tells us is a short delay in treatment leads to a dramatic increase in bottle use and discomfort for mom. And, I don't know if you're familiar with the Cochrane Group, but they're out of the UK. And in 2017, they looked at tongue-tie research, and they typically look at the highest level of research and throw out a lot of studies that don't meet their criteria. So their recommendations are quite strong when they do make a recommendation. And one of their recommendations was that frenotomy reduced conclusions, I guess. Frenotomy reduced breastfeeding mothers' nipple pain in the short term. So we know that nipple pain is one symptom that can definitely be improved with tongue-tie release. And of course, if mom's having a lot of pain, she's not going to breastfeed most likely. So, and another positive note is that there were no serious complications in the studies they evaluated, which is great. We've never had a complication, which is good. And overall, a very safe procedure pending the technique you use and the materials. So, and of course, further trials are needed, and that's obvious. We need a lot more research in this topic, and like many topics in healthcare, we, the more research we have, the better recommendations and better techniques we can use. So, the good news is, like I said, we're in the highest breastfeeding rate in the past 50 years. So what happens when more moms are breastfeeding their children? Well, you're going to have more breastfeeding difficulties. You're going to have more ankylglossia or tongue-tie diagnoses, and you might have more procedures being done. So this is there are definitely some individuals that say, well, I don't know how much a tongue tie plays into breastfeeding. Maybe it's just a fad. Maybe infants are having it done. And this definitely doesn't shed a good light on the topic, as pending insurance or whatever, more infants are treated. And I think part of that is misunderstanding of diagnosis, not working as a team. There can be issues of over treatment of infants, and so that's why I think IBCLCs are so important and working together. I think if some people have soft tissue laser only, that's all they're using it for. So I think it just goes back to coming up with a objective evaluation, and then working as a team with your other specialists like IBCLCs to come up with appropriate diagnosis, and making sure that treatment is warranted. So here's part of our screening process. This was developed from Bobby Gary's screening form as well. And this helps us determine if a frenotomy is needed. And so what we do is we make sure they have a lactation consultant, because I think that's very important. That's going to increase your success and outcomes. We check, of course, how's the weight going? Have they gotten vitamin K? And we look at symptoms, same thing, baby symptoms. Or they have other medical issues, but baby symptoms, poor latch. Do they fall asleep? Are they colicky? Are they having reflux? I mean, these are all tongue tie related symptoms. And then we look over at moms, of course, bleeding, severe pain, poor drainage, plugged ducts, that sort of thing. And since we know there's a family history, we have that family history of tongue and lip tie area, and then, other issues. So I think, another key is spending a lot of time with the families to see what their goals are. What's the mom goal? Is she transitioning to the bottle because the baby's older now and they're done breastfeeding? Well, does it make sense to intervene? It probably doesn't. What's the motivation for seeking treatment? And I really focus on breastfeeding alone. I mean, it's hard to say that, oh, well, now you'll have speech problems if you don't get this corrected now. Well, sometimes that's not, we don't know. So I think it's just really looking at the big picture with families, and intervening if needed. And there's lots of ways to do frenotomies, and they can all be successful. In the past, I'd used scissors before we had the technology to use carbon dioxide laser. Scalpels also used. I think one thing about those two techniques is you'll need potentially anesthetic, which with laser you don't. And you get bleeding, sometimes suturing. There definitely can be more complication. I don't think it's as precise. So that's the problem with scissors and scalpel, although it's used by many people around the world. And then when you look at lasers, there's diode lasers. Basically, that just burns the tissue. The difference is in a carbon dioxide laser is that it actually vaporizes that tissue, and it's very precise. And I'll show you a few cases. So, what are benefits of using carbon dioxide laser? You get a char-free bloodless surgery. So these are all things that, we would look at and would want in having an infant surgery is no blood, no anesthetic. You get coagulation depth of the laser matches the blood capillary diameter, so you don't get bleeding, which improves surgical field and allows for really precise removal of tissue. You can control the speed and depth of cut, which is very important in my opinion. You can do micrometers up to millimeters of tissue removal, and then you get less swelling, better postoperative fast healing. So that this is why the transition is being made by individuals that do this procedure for infants. So we'll just go through a few cases. Obviously, this isn't an infant. If they had this many teeth, that would be interesting. But this is a 3-year-old with a class 4 lip tie. So you can see how thick the frenulum is. And it attaches all the way on the palate. So there's lots of tension here. It's blanching. You can't lift the lip up at all. And so this child, the parents' concern was, well, there was quite a large diastema or space between the teeth. I can't brush my child's teeth. There's plaque. It's very difficult to clean. So that was their reason for seeking treatment. And so we revised that. And, now you can see the lip flanges out completely. And in 6 months, those teeth came together beautifully. The parents could brush. And same thing at a year now, all the way together, easy cleaning. These are really the goals of treating these infant lip ties. This is also another older child, but it's easier to see the anatomy on these cases. So here's a 7-year-old with a class 1 tongue tie. Like we talked about, the tongue is used for cleaning too. So this child has already had some restorative treatments, some crowns and things like that. It's maybe had early challenges with dental cavities. And so the tongue will move laterally and clean the teeth, and that might have played a role in early decay. But this child could barely elevate their tongue at all. So we'll go through what it looks like to release frenulum. And you can see the green aiming beam, and that helps you kind of really spot where you're releasing. And the frenulum is layer by layer. You're removing that tissue, the collagen, the elastin, the mucosa. And like I said, the goal is to get down to removing that restriction of the tongue. And this is an important piece. You kind of regather and put lots of tension. And you'll notice we did get a little bleeding right at the top there, but that's not where the laser is hitting. It's just because there was a superficial vessel that was released and exposed when we released the frenulum. So it's a pretty quick procedure, and this is actually in slower time. Just a relatively quick release, and I'll show you kind of what it looks like as soon as we get the release done. So this is that same frenulum afterwards, and you can see what the goal is. This is a bloodless surgery. You can see, and I'll kind of outline, maybe if I can. You'll kind of see where there's a diamond shape release. So that's released all the restriction under the tongue. There's no other tension. And that's really, you can swipe all the way underneath. It's nice and smooth. That's kind of, this is what you're going for when you release tongue restrictions. And, you can see kind of the before and after. Here's another video. It's hard to videotape infants. so this is an older kid, but I'm going to do some infant cases here in just a little bit. But you can see, you can peel layer by layer of tissue, like I said, without anesthetic, without bleeding. It's quick and efficient, and much more comfortable for the child. So that's that fast. Here was a case of a 2-day-old infant. This was the family's first child, and they had they marked many boxes on our form, several breastfeeding issues. And we try to do same-day treatment if we can to, obviously we know the earlier correction, the better. This I would classify as a class 1 tongue tie because it's very tip of the tongue and it's attached to the mandible or lower jaw. So it's really not surprising that the mom was having challenges with breastfeeding. So this is the frenulum that's tight. This is immediately after. And actually the attachment point, this tongue elevated so well, it jumped off our PowerPoint, but it's actually up above where that tongue was attached. And you can see underneath the tongue, that's actually the genioglossus muscle. So that's the goal, is to get that uninhibited. And so mom was able to feed right away, and the efficiency of feeding improved significantly. And that's kind of, that's what we're going for. The same thing, here's a young infant that had lip and tongue tie. So another kind of, maybe this is more of a class to tongue tie because it's a few millimeters back. But you can see the immediate release and how the top of the tongue is really restricted, and it's the middle portion of the tongue that's kind of held up, and then after the procedure it's elevating all the way. Same thing with the lip. You can see where the lip is notched in, and it's a very wide attachment. So those are typically, a lot of tissue there, very wide attachment, notched in the bone. This is a lip that's not flanging out. So immediately after the procedure, it's flanging out, and ease of latching was significantly improved. And this is kind of a tough case. So this is what we're talking about. So even though we kind of focus on the anterior tongue ties, posterior tongue ties can be just as challenging. For moms, you got to really do good evaluation and look at symptoms and have your IBCLCs. They're the most important in terms of helping with mother support. This tongue doesn't look like much, but it looks like the frenulum's under the mucosa, but it almost looks like a mushroom. It's very wide stalk. The shape of the tongue is very bunched up. So this tongue really wasn't elevating very well, and that's what I picked up on right away. I did the release, the tongue elevated really well afterwards. It changed shape. And, I include this little letter from our lactation consultant that did a fantastic job of catching it. But the baby was 12 days old. The lactation did all they could, and they do a fantastic job in our area. So they worked on positioning, worked on support, but still a lot of pain with breastfeeding, difficulty breastfeeding. So I showed you the release of that posterior tongue tie. And 5 days after the frenotomy was performed on the tongue and lip, no problems with pain. She got rid of pumping and bottle feeding, was able to breastfeed exclusively. So that's really, hopefully my role in the community. I'm really just the technician. I have a lot of great support around me to allow sort of this early diagnosis, early treatment as indicated. I'm happiest if we don't have to do anything, but sometimes those restrictions really limit mother's availability or ability to feed. So that's really my role. And so, of course, with anything, there can be complications. I've treated around 800 infants over the last 3.5 years. And we haven't had any complications. I would say the most common problem is several hours after the procedure, it is a little sore sometimes for the infant. And so feeding may not go as well that first day or two, but that's it. But, other things I've noticed and noted in the literature is knowing what you're doing. If you get vessels or you don't release appropriately, you can have, potential bleeding, respiratory events. That's why I use laser, so I don't get bleeding. Damage to the lingual nerve. So again, knowing the anatomy, knowing where you're going. Weight loss if they kind of protest the feeding afterwards. And then there could be other issues, medical conditions like heart disease. So we kind of focus just on one thing. Other things can be missed. So I think that, like I said, it's thorough evaluation, thorough work with your other providers to give you the best results. And kind of quick take home is that we know that mid-tongue elevation is the key to breastfeeding success in terms of the tongue mobility. If that middle part doesn't elevate, you're going to have a hard time creating the vacuum in the latch. Proper examination technique, again, that's kind of knowing what to look for, knowing how the tongue moves, not just where it attaches, and proper release, knowing the anatomy and release. And so, going back to that very tip of the tongue, class 1 Coriolis tongue ties, I don't really see a reason not to release those because they're very restrictive and they could definitely lead to other challenges down the road. It's uncommon for a lip tie to be the sole cause of breastfeeding difficulty, but we do look at other things from a dental perspective, as we discussed. But typically, lip alone is not the challenge, not the main problem. If all other interventions fail, meaning seeing IBCLC, working with our other providers, if they're unable to help that mother, infant, dad with feeding, then we can look at tongue tie as a cause. But I think early evaluation diagnosis is critical. And the good news is we have the technology available today to do these releases without the need for anesthesia or sedation or even anesthetic. So it's a very safe and quick procedure and can easily be done in office thanks to technology. And again, I can't stress it enough. Early evaluation intervention is really the key. And working as a team. So working with our great providers in Kittitas County, we can get great outcomes. So yeah. What other questions? I think that'll wrap it up.
So, that was fascinating. I learned so much. It was great.
Yeah, good. I'm glad you enjoyed it.
Thank you so much.
Yeah, my pleasure. Yeah, it's a topic that I've spent a lot of time on and a lot of training on. And, like I said, fortunately, a lot of medical providers and dental providers and organizations are spending some time and giving its due to, like I said, help moms that want to breastfeed.
So Dr. Smith, do you feel that the increase in diagnosis of tongue tie and lip tie am I correctly taking in what you said that it's probably associated with the increase in breastfeeding initiation rates?
Yeah, that I don't know for sure, but yeah, that's my take is that as the interest in breastfeeding's increased, people are seeking out IBCLCs. They're seeking out and looking at that early on. So I think that's resulted in better diagnosis, right? So even 15, 20 years ago, we didn't even have a system to appropriately classify these. So I think it's helped us with diagnosis, classification, and increased breastfeeding. You're going to have more potential diagnosis. And like I said, it's working with other providers first, and then okay, well, this is definitely creating a challenge for the family. Like I said, fortunately, we have an easy procedure now to do an easy, quick release and get those family breastfeeding if that's their desire.
That makes sense, because I have heard that from other from nurses and other people that it seems like the rates of tongue tie have gone up, but it's probably it's always been there. It just hasn't been diagnosed, and people maybe haven't gotten the breastfeeding support that they needed for referrals and diagnosis of that.
Right. Yeah. Yeah. And I think unfortunately in the past, maybe it was like, well, breastfeeding is supposed to be uncomfortable. Well, just deal with it, and how it goes, it goes. Now we know, well, yeah, there could be some early intervention that's done to eliminate the discomfort or problems associated with breastfeeding. And I think, in my experience, the pediatricians and other providers are actually seeing the results when the babies come back and they're feeding. And like, wow, okay, yeah, I guess, that makes sense, so.
I know our lactation consultant, Rosika, definitely sees the improvement. So.
Right. Yeah. And that's the goal. I mean, we want to get close to 100%. If we do have to intervene, then we want 100% success, but it takes a team effort. And like I said, evaluation diagnosis is really critical, and parents' desire too. So. Right. But yeah, I think that's and I think because there definitely, we know there's a genetic component to it. That it's not it's something that's easily passed on with how it's so I think there probably is a little higher incidence. And like I showed you in the study from Spain, they really got all the providers on the same page. They evaluated, and we can see the oral restriction is actually a little higher. But I think you have to have oral restriction with oral, where does it attach? How does it move? What symptoms do we have? You have to put all those together to say, okay, now it's time to, look at a intervention to release. So.
Well, thank you so much. This was excellent information, and we really appreciate you taking the time to present this to us today.
Yeah. My pleasure.
And I'm also going to say thank you to anyone at home who has joined us or will be joining us and watching this webinar. We hope to have many more such educational webinars coming up. And if there's a topic that anybody watching this is interested in having us present, please contact us with your idea. The contact information is listed in the video description. And again, Dr. Neal, thank you so much
Oh, my pleasure. Thanks for
for
having
your
me.
time and your willingness to be here with us.
I'm happy to talk about it. So
Our first webinar. So
yeah, I think we nailed it, Julie.
I think so too. I think so too.
All
Thank
right.
you.
Yeah, thanks. Take care.
You too.